Well, hello, and thank you for joining us on the ASAP Capital Minute, a biweekly look at the latest developments from the nation's capital that impact emergency physicians. I'm Laura Wister. After my update, we'll open it up for questions. You can submit them at any time by using the Q&A feature at the bottom of your screen in Zoom, and then I'll answer them live. So today we'll cover regulatory update on the surprise billing interim final rule from CMS, the Medicare hospital payment regs, and the new physician fee schedule, a legislative update, including the ED mental health services bill, and then what you can expect at LAC this year. Our regulatory colleagues have been incredibly busy for the last several weeks. Just before the July 4th holiday, the Departments of Health and Human Services, Treasury, and Labor issued the interim final rule that we've all been waiting for to implement part of the No Surprises Act, landmark legislation to take patients out of the middle of billing disputes between insurers and physicians. The No Surprises Act bans balance billing for out-of-network services starting in 2022, and establishes an ASAP-supported independent dispute resolution or IDR process to ensure that clinicians and facilities are paid appropriately for the services they deliver. ASAP has a comprehensive summary of the IFR available for members, and you can find more analysis on our Regs and Eggs blog. But here are some of the highlights. The IFR is the starting point of the implementation process for a rule. It focuses on some major issues that impact how much patients will pay for out-of-network emergency care and certain services. However, the IFR does not offer details on the IDR process yet, which in some cases will determine the payment that a clinician or facility will receive for an out-of-network service. Another IFR that will focus on these other issues is expected later this summer or in early fall. But comments on this first IFR are due on September 7th coming up, and ASAP and the Emergency Department Practice Management Association, or EDPMA, plan to submit a comprehensive response to the rule. We can all be pleased that Congress and regulators recognize the importance of addressing the root cause of surprise bills, narrow insurance networks, and insufficient coverage. Once enacted, this law will take important steps to remove patients from costly and potentially dangerous scenarios that arise when a patient's insurance falls short and ensure that you get the reimbursement that you're owed. One huge win for emergency physicians and patients is that the IFR strongly reinforces the prudent layperson standard. The prudent layperson standard allows people who reasonably think they are having an emergency to go to the ED without worrying about whether their insurance will cover the visit. The standard is based by the principle that insurance should be based on a patient's symptoms, not a final diagnosis. And we all know that insurance companies continue to demonstrate a dangerously loose interpretation of this patient protection. As a recent example, United Healthcare recently announced a policy to retroactively deny patients emergency care claims. You may have seen the swift and strong reaction led by ASAP on the Hill and major publications like the New York Times. After feeling the pressure from physicians and patient advocates, the insurer quickly reversed course and chose to delay implementation. We can all be pleased that this new IFR directly addresses these bad behaviors by explicitly stating that these tactics are inconsistent with requirements of both the No Surprises Act and the Affordable Care Act. The IFR also emphasizes the determination of whether the prudent layperson standard is met must be made before an initial denial of an emergency services claim. ASAP efforts to expose insurance company maneuvers are clearly working, and federal policymakers are noticing the need to address retroactively denied coverage of emergency care. This reaffirmation of the prudent layperson standard helps ensure that patients no longer need to hesitate or delay seeking emergency care over uncertainty about their insurance coverage. Also under the No Surprises Act, the qualifying payment amount is used to determine cost-sharing requirements for patients if an all-payer model or specified state law does not apply, and as a factor that IDR entities can use to determine the total payment they think is fair for out-of-network emergency services. ASAP and EDPMA had asked CMS and other federal agencies to require healthcare plans to base the qualified payment amount, or QPA, on the specific CPT codes included on the initial claim, in part to address the underlying issue of downcoding, another insurer tactic that we continually are fighting against. If the healthcare plan can base the QPA on a code that they think should be attributed to the service delivered, not necessarily the CPT code that was included on the claim itself from the provider, then that could keep the door open for them to continue downcoding claims. Although the IFR would require healthcare plans to base the QPA on the specific code for the service delivered, it does not include the explicit reference to the CPT code on the claim that we had requested. That's disappointing, but we hope that federal agencies will dive more into this issue of downcoding in the next IFR that focuses on the IDR process itself. The IFR is hundreds of pages long and delves into requirements for initial payments, how and when billing scenarios are subject to applicable state laws rather than this new federal framework, dispute resolution, and more. You can expect more details in the coming month as we continue to analyze the rule and finalize our formal comments, which we'll share with you once they're ready. In other regulatory developments, ACEP has provided comments on the fiscal year 2022 inpatient prospective payment system proposed regulation, which addresses CMS plans to add, modify, or eliminate measures in Medicare's hospital quality reporting program. ACEP heard your clear concerns about the proposed elimination of the ED boarding measure starting in 2024 and strongly opposes its removal. Further, we've stated that boarding in the ED should continue to be tracked diligently and that this measure is absolutely necessary. The CMS position relies heavily on one analysis that looked at 12 studies that did not find a clear association between ED boarding and in-hospital mortality. ACEP disagrees with the CMS assessment because there are indisputable data showing the opposite to be true. Our response cited nearly 70 studies that demonstrate the link between boarding and patient morbidity and mortality. We know firsthand that crowding leads to increased mortality related to downstream delays of treatment for both high and low acuity patients. Boarding can also lead to ambulance diversion, increased adverse events, preventable medical errors, lower patient satisfaction, violent episodes in the ED, and higher overall healthcare costs. We've offered to meet with CMS to walk through these studies, and we're hoping that they'll take us up on the offer. Due to the pandemic, CMS proposes to suppress most measures under another hospital reporting program, the Hospital Value-Based Purchasing Program, in 2022. By suppressing the measures, CMS will not have enough data to give hospitals a hospital value-based purchasing score, which means that hospitals will not be eligible for any positive or negative payment adjustments based on their performance in the program. Another part of this proposal is that CMS will distribute funds for 1,000 new Medicare-funded residency positions. The statute does not distinguish between specialties, and we believe CMS should make an effort to fund programs for specialties where there are the most shortages. And hot off the press, just yesterday, CMS released a Medicare annual payment rule for calendar year 2022 that impacts payments for physicians like you and other healthcare practitioners. There are some beneficial changes included, and we will have a detailed summary on our next Regs and X blog. But here are 4 initial takeaways that will impact your practice. Congress needs to act to avoid physician cuts. Due to the Centers for Medicare and Medicaid Services decision to increase the office and outpatient evaluation and management services in 2021, there is a budget neutrality adjustment as required by law. Congress was able to offset the majority of the budget neutrality cut that was expected to go into place in 2021 in the Consolidated Appropriations Act that was passed at the end of the year. Specifically, Congress added back 3.75% to the conversion factor. Now, going into 2022, Congress would again need to act, or the conversion factor will be cut by that same 3.75% that we were able to avoid before. Telehealth flexibilities are also extended. ACEP has been advocating to extend or make permanent the flexibility that CMS temporarily approved for Medicare telehealth services during the COVID-19 public health emergency. With this new fee schedule, CMS placed all 5 ED/E&M codes, levels 1 through 5, the critical care codes, and some observation codes on the approved telehealth list for the remainder of the year, even after the public health emergency expires. They indicated that they will seek additional data to inform any decision to make these changes permanent or not. The appropriate use criteria program will be delayed to January 1st, 2023. The program has already been delayed several times, most recently to January 1st, 2022. It would require clinicians to consult appropriate use criteria using clinical decision support tools prior to ordering advanced imaging services for any Medicare beneficiaries. Emergency physicians are exempt in circumstances when your patient could be having a medical emergency, even if symptoms resolve, a change that was made due much in part to ACEP's advocacy several years ago. Now, CMS is proposing to adopt the emergency medicine-focused MVP that ACEP developed. CMS has heard feedback, including from ACEP, that MIPS reporting should be streamlined and more meaningful to clinicians. The voluntary MIPS value pathways, or MVPs, will allow clinicians to report on a uniform set of measures on a particular episode or condition in order to get MIPS credit. The first batch of MVPs, which includes ACEP's MVP, will start in 2023 in order to provide practices the time they need to review requirements, update workflows, and prepare their systems as needed to report MVPs. ACEP continues to work with Congress on issues that strengthen emergency medicine. A recently introduced bill represents another win for emergency physicians and patients who want to see progress in a very important area, mental health services. In late June, Senators Shelley Moore Capito of West Virginia and Maggie Hassan of New Hampshire introduced the bipartisan ACEP-supported Improving Mental Health Access from the Emergency Department Act. This legislation would establish grants to EDs to support follow-up services for individuals who present for care of acute mental health episodes. These grants would be used to create, support, or expand programs intended to expeditiously transition these individuals who are treated at the ED to an appropriate facility or setting for follow-up care. The House version of this legislation, sponsored by emergency physician and Representative Raul Ruiz of California, was approved on May 12th. As we know, the pandemic has exacerbated an already growing demand for mental health care services due to rising rates of mental health conditions, substance abuse, and suicide. This increased demand, as well as a shortage of psychiatric beds, is causing patients to remain in emergency departments until appropriate mental health care is sought. This bill provides resources for emergency departments to adopt more collaborative and connected care models and to deploy new technology to better connect patients with appropriate resources in their communities. Looking towards the end of this month, ACEP's Leadership and Advocacy Conference is right around the corner. There's still time to register for our annual event in DC, and LAC is an incredible opportunity for you to advocate for your specialty, and we are very excited to welcome you back to the nation's capital for those of you who are attending in person. We've identified 3 priority issues for LAC this year: patient access to MAT, physician mental health, and protecting emergency physicians from harmful reimbursement cuts. You'll have a chance to meet with your legislator and explain how emergency physicians are critical in the fight against the opioid epidemic and advocate for increasing access to MAT and eliminating the X waiver. This is also a unique chance to encourage Congress to take actions to change the way we address physician mental health in this country and address the stigma that too often prevents physicians from seeking the help they need. And you can make it clear in human terms what it means when reimbursements in Medicare are cut. We need Congress to take action to avoid cuts that are otherwise planned to take effect. Now is the perfect time to join us in DC, either in person or virtually, and let your voice be heard. It's not too late to register, and for those attending virtually, you'll be able to participate in the congressional meetings as well. Registration is at acep.org/LAC. For those of you coming in person, despite the congressional meetings being virtual, there will still be plenty of face time with legislators. Senator Tim Kaine will be there in person to discuss physician mental health. The leaders of the Bipartisan Problem Solvers Caucus, Representatives Brian Fitzpatrick and Josh Gottheimer, will give their perspective on how to get things done in a divided Congress. The congressional reception that's going to be Tuesday night at the hotel should see some congressional faces stopping by as well. We'll also have a unique opportunity this year for you to stop by an event we are hosting along with the Future Forum, which is a coalition of younger members of Congress working on change for the next generation. And as always, NEMPAC is hosting in-person dine-around events at LAC 21 as a unique opportunity to discuss healthcare policy and the national political environment in small group settings. To find out more or to sign up for the Future Forum event or the dine-arounds, please contact Jeannie Slade at jslade, S-L-A-D-E, at acep.org. You'll also hear in the LAC program directly from influential staff of the Ways and Means Committee. We'll help you sharpen your skills in planning and strategy sessions, and then you will get to go to bat for emergency physicians with your member of Congress. With so much at stake, this truly is a can't miss experience for any physician advocate. We'll also be hosting a workforce town hall on Monday morning with ACEP leaders. There's been a lot of discussion about what the job market will look like in years ahead and what ACEP is doing to address a looming job crunch. As part of our workforce-related conversations, we'll be unveiling some new public information about just how much patients trust emergency physicians and prefer being treated by you in an emergency. This forum is your chance to talk to ACEP leaders and discuss the future of the specialty. We really hope to see you there. That concludes this week's Capitol Minute. As a reminder, this episode and all others are available at acep.org/Capitol Minute, and I'll be happy to take your questions now. See, first question is coming in. How receptive are Congress and the staff to hearing about the real dangers of the Medicare cliff? How does the new PFS rule impact those conversations? So I think they're receptive, but they've also heard it before, because unfortunately it's something we've had to advocate for many years. So it's always good to put a personal story along with it, which is where you all come in, coming to LAC. And in these meetings, you're able to tell a much more personal story about the need for this reimbursement than we are as ACEP staff. So that's going to be really important. In terms of how the new rule impacts those conversations, it actually helps a little because, as I mentioned, that 3.75% cut, we were expecting that we might need to advocate for that to be stopped again this year, but it wasn't certain yet. And so without the proposed rule, you kind of be advocating for something against something hypothetical, which is never that effective as advocating against something bad that's going to happen that's actually real and will happen. So with that proposed rule now, we can point to it and say the recent proposed rule will result in a 3.75% cut at the end of this year. Therefore, that's something we need Congress to help us stop like they did last year. So it's a lot easier and more concrete an approach. If there's other questions coming in. How are the Hill meetings working at LAC? Are they virtual? So yeah, they are virtual this year. We were hoping they'd be in person, and really until it's all been very uncertain, even until earlier this month. And then we finally realized, I think had enough information that Congress definitely will not be taking in-person congressional meetings with constituents in DC by LAC. So we've pivoted to doing those virtual. But as I said, the rest of the program has lots of in-person FaceTime with legislators and with all of you and with ACEP leaders. So we're pretty excited about that. For the Hill meetings themselves, Soapbox is organizing them. They'll be over like a video chat. It won't just be a phone call. So it's Zoom, but it's a different platform, like Zoom, but a different platform. And everybody will get their meeting assignments like they've done in previous years on their schedule. They'll just get a link to access it instead of going in person. And then we're going to arrange for groups if they want to be able to do these together. Where possible, we'll try to make sure that they have space to do that. Folks can also do them from their hotel room, whether alone or in groups. Probably a better bandwidth up there than in the hotel meeting space, but we want to make sure that folks have a chance to consider doing these together. So a lot of this will be explained at LAC itself, but it's definitely going to, I think, be a fun way to do it. And we'll have some shared experiences, even though the meetings themselves are going to be virtual. Another question is, can people at home participate in the virtual Hill meetings? So yes, absolutely. If you're registered for LAC virtually, you can participate in the Hill meetings, and you should have already received some information about that to help arrange that. But if you haven't, just reach out to Jeannie Slade at ACEP, and that's jslade@acep.org to do that, just to make sure you're taken care of. If you haven't registered for LAC, but you want to attend virtually, you can still do that. So that's at acep.org/LAC. And the programming will be Monday, most of the day. And then Tuesday morning, there'll be virtual programming. And then Tuesday afternoon are the Hill meetings, which again, you can participate in from home virtually. So looking forward to see if more people want to join us for those. We'd love to make sure that just about every part of the country is covered by ACEP advocates. Another question coming up. You mentioned ACEP is releasing data from a recent public opinion poll on some of our workforce issues. Is there any data you can share? So yeah, one thing that was interesting, so we want to, as we've taken up new efforts to help advocate for you on scope of practice issues, one of those things that we recently did was ACEP joined the AMA Scope of Practice Partnership. And we wanted to make sure that we had some emergency medicine specific data to speak from, because right now most of the stuff on the AMA Scope of Practice, since ACEP is only new to it, was for other specialties or just generally. But we wanted some of our own. So we put out some polling questions on that along through Maureen Consult, if you've heard of them. And we'll share more at the Workforce Town Hall at LAC, and then kind of beyond that with you. But one kind of interesting fact that we saw is 20% of adults aged 18 to 34 would use the color of a healthcare worker's scrubs to determine if they are a physician in the ED. So I think that shows that there's a lot of confusion. But the poll also showed that it's very important for people that they be treated by a physician when they're in the ED. I think over 90% of them said that that's important to them. So I think we need to better connect the dots for them or help them advocate for themselves to know whether or not they're being treated by a physician, and to be able to, I think, ask for that and advocate for themselves. So this is just like the initial data, and we have a lot of work to do to turn this into some compelling advocacy, but I think it's going to be really effective, and this is a great first step. So stay tuned for more on that. I think this might be the last question. It seems like some things are happening in our local EDs that I might want to raise to my member of Congress. Can I do that during LAC? So we kind of have the three issues laid out for LAC, and we'll be providing materials in terms of your talking points and issue briefs. And we've chosen those issues kind of based on a variety of factors. And it's kind of planning to go into the meetings. It makes more sense for all our advocates to stay on message with the same messaging. It's much more impactful for Congress to hear from many of you the same needs and asks than if they just hear like hundreds of different ones. So that's why we have those three issues, and that's why we picked them and have you talking about those. That being said, if there are things happening in your local EDs that you want to raise to your members of Congress, after LAC is a great opportunity to do that. You had your meeting with your member of Congress or their staff, is absolutely appropriate to email them afterwards a thank you for meeting with you and send them some additional information and raise your issue. That way they'll already have a face with a name and your email will be paid much more attention to. So definitely encourage you to do that after that. That's kind of where we are in terms of the three issues. We picked them this year because really they hit the sweet spot of where we can actually move the needle if Congress hears from you, and what's of importance to a lot of emergency physicians can really make a difference in your lives and those of your patients. And so that's, the MAT, that getting rid of the X waiver is a huge issue right now, can help a lot of patients and make your lives easier. Medicare reimbursement, as we said, is pretty darn important. And then the Dr. Lorna Breen bill will help ensure physician mental health resources are available to you, and that a lot of future issues can hopefully be averted and really provide peace of mind for everybody. So that's kind of where we are now. So we're looking forward to seeing you at LAC. Just a reminder that the next Capitol Minute on July 28th will be canceled because of LAC, but then we look forward to seeing you in August with some updates on what happened as Congress closed out the summer session. Thanks again.